Thank you, Fiona, for introduction. So in these sessions, we're going to talk about how to use patient data for improvement work. And first, I will present the method of record reviews. And the next speakers, I will present quality registers. Someone is skipping the slides. And we will tell you about what we can achieve with each of these methods. So I'm a physician in breast and endocrine surgery specialty in Nordland Hospital Trust, and I also is a research fellow of the Arctic University in Tromsø in northern Norway. I also work as a patient safety advisor in our trust. And I will tell you about the experience we had when we implemented the Global Trigger Tool as a record review method to measure adverse events in our hospital trust. So now is the interaction begin. And I want you to use your paper, which has a cross or a tick. And the crosses is a foreseeable complication, and the tick is adverse event. And I will list certain situations, and I want you to vote what you mean is a foreseeable complication or if you think it's an adverse event. So the first situation is a patient who is admitted to the hospital, and he or she falls in the bathroom and experiences a fracture. So those of you who think it's a foreseeable complication, use the crosses, and those who think it's an adverse event, use the ticks. So only I can see the answers. Okay, next one. A patient having a surgery, and she or he experienced a wound infection. What do you mean it is? Okay. The next one is a planned replacement of the hip, and the patient needs a blood transfusion after this surgery. Okay. And then there's a patient who's having a urinary catheter and experiences a urinary tract infection. Okay, and the last one is a patient who is admitted to the hospital, and he or she got a gastroenteritis while admitted. Okay, thank you. So many of you vote for a foreseeable complication, and many of you use the adverse event situation for these situations. And in our trust, before we implemented this global trigger tool, we had a culture focusing on using the words of error and blame and harm. But we needed to rethink about this and try to focus on the system around the patient, because the main focus should be the suffering of the patient and not what we call all the situation. And this is the main focus in the Global Trigger Tool, which is developed by the Institute for Healthcare Improvement, and then define these events as an unintended physical injury resulting from or contributed to by medical care that requires additional monitoring, treatment, or hospitalization, or that results in death. And we had to build a culture to focus on the main outcome, that is a suffering for the patient, not if it was a foreseeable complication or an adverse event. But mostly important, all of these events are to be avoided so the patients don't need to suffer. The Global Trigger Tool is a manual review of the record retrospectively, and is 57 triggers in the Norwegian translation, which 2 primary reviewers search for in the records. So they look for if there's been a transfusion of blood products, or if the patient has been falling, or it's been a reoperation, or things like that. And these triggers could represent an adverse event. And if they found an adverse event, they will categorize this event in one of these types and categorize them to the severity level. If it was just a temporary harm, recurring intervention, or it was more severe that the patient had a permanent harm, or it led to a patient death. But when we started to talk about this record review method in our trust, we met resistance among the health personnel. Some said that this method only included small samples of the records, and we hadn't had And they meant that they didn't have any more researchers to look into more records. And some said that the harm wasn't happening at our department to our patient. They felt that they only owned the patient who was in their division, and they didn't see the whole perspective from the patient. And some said that the record review didn't find the important adverse events, like the most severe, and they didn't trust the results from it, didn't think it was reliable. And others said that we already respond to all errors in our department. So we had to do something about all these challenges among the clinical staff. What we did, so we started with local review team in each division. So we didn't do a review from the whole hospital for one. We did a sample from each of the divisions so that the teams from each division could analyze their own patients. And we also developed an automatic search for the triggers in cooperation with the SAS Institute. So run through computer algorithms, they could find the triggers that I was showing before automatically, and they flagged the records where these triggers were found. So it saved some researchers to do it automatically. And we also had to adjust the sample size, we thought, because in our trust we had 3 different hospitals, 2 minor hospitals and 1 larger. So we thought that we needed to adjust the sample size according to the hospital size. But then we had the question, what is the correct sample size? And who is it appropriate for? And do we review the relevant records if we choose too few records in one hospital and maybe too many in another hospitals? And who should it be correct for? We thought that when we give the results back to the division, we needed them to think that the results was reliable. So we needed to choose a sample size that they could be trusted that we were reviewing their relevant records. And in order to be statistically correct, there is sometimes used a power calculation, but then you need to know the rate of the adverse events and then say how much percent do we want to reduce the adverse events, and we didn't know that before we started. So we come up with research. That's always a good thing. And by evaluating 2 different sample sizes, one sample sizes with the recommended 10 records selected randomly biweekly, and we compared it to a larger sample size, which we selected in the same way with 70 records biweekly. And we did this through 1 year in the period of 2010. And we found that there was a different rate. So this is the mean number of adverse event per 1,000 patients day. And in the large sample size, which is the blue, it was approximately 40 adverse events per 1,000 patient days. And in the small sample, which is the red dot, it was 27 adverse events per 1,000 patients days. So we found a different level of adverse events in the different sample sizes. But we didn't find any difference when we looked into the categorization of the adverse events. So in both samples, the less severe events was both E and F, which is the less severe events, approximately 40 to 50%. And there was a small number of the most severe events in both samples. We neither did find a difference in the categorization of the types of adverse events. In both samples, it was the hospital-acquired infection that was a dominating type. And then came the surgical complication along with the bleeding or a thrombosis. So the implication we found was that maybe we should adjust the sample size to the hospital size. Or maybe a new increased fixed sample size is needed, not the 10 records biweekly as it was recommended. But to evaluate and identify the types and severity of adverse event in a trust, you only need to pick a small sample size to map your adverse events. So when we measure the adverse events, we got a lot of results presented as adverse events per patient stay or per admissions or the percentages of the admissions with an adverse events. But if you don't use them back to the divisions, it's not necessary to measure them. And you have to think about how you present the data so the audience can understand what you are presenting. And are you giving a report to the health authority? They need something else that the staff and the patients need. So you have to have that in mind when you share your results. The most important is to share your results. Don't put it in the drawer. You have to be transparent, and the results needs to be visible and available for all the involved staff in each division. And you have to have a simple and clear presentation, not a complicated graph that won't work on the walls of the hospitals or in the internet websites. And you need to update your data. Don't use old data because no one will think about your data if they're not fresh. And use all your encounters. Speak to your leaders when you are having your meeting with the CEO. Maybe they go on the quality rounds, they do in our hospital trust, and they ask if they are using the results from the J.H.E. And also encourage the local leadership to present the results in each divisions in order to do some improvement work in the local department. So when everybody comes to our hospital, they are met with a screen where it says how many of the patients are harmed every year. And this is from 2014. And you can see that 1 out of 5 of the patients is harmed in our hospitals. It's in Norwegian here. And it also says on the screen what we are doing to reduce the adverse events and how many of the adverse events is severe and how many are less severe. We also invited the local press to present our results to the community and to share our improvement work so the community know what we do in our trust. You can also follow the level of adverse events through processing them in statistical process control charts. As I said, we don't find the correct rate of the adverse event by using a small sample, but if you use the same way of sampling records every year and the same size, then you can track the level to see if it has decreased or increased by using the statistic process control tests. So this is from the surgical department who has had a shift and increase in their rate, so they needed to address that. Or you can use it to evaluate the effects of different initiatives that you have started in the local departments. For example, in the orthopedics departments, they had a quite high number of postoperative bleedings that we found through the record reviews. And we addressed that to the surgeon there, and they started with a medication before the planned hip and knee replacement. And then we measured the postoperative bleedings the next years, and we found that for 2 years ago it was 0. I haven't analyzed the 2015 data yet. Another initiative was that we are following the postoperative infection after surgery, and we implemented the safe surgery checklist in 2010, and hopefully we could see a reduce in postoperative infection in that. But still we were using the checklist in 95% of the cases. We still had a quite high number of infection. So we started to evaluate how we were using the safety checklist, and we discovered that we might not do it the appropriate way. So we started to go back to the questions and responded to the areas where we didn't do it right correctly. And hopefully we will decrease in infection the next year. The last example is about adverse drug events. When we started medication resilience in 2013, you can follow the level of the adverse drug events in the J.H.E results. And also, we showed it to the health personnel who had the resistance to use the record review as a measurement. We compared the results that we found in J.H.E with the voluntary incident reporting. And I was curious about what do you think we found? How many of you thought that we had found 0 to 1% of the adverse event in J.H.E was found in the incident reporting system You can raise your arm now if you think that was the situation. How many of you think it was 10 to 40%? And how many think it was up to 100% in both registers? So we didn't find any of our adverse events identified in the GTT in the voluntary incident reporting system. We experienced that in our voluntary incident reporting, it was almost only near misses who was reported and not actually harm that caused suffering among the patients. And that was back to the interaction we had in the beginning, that many of the health personnel looked at the wound infection as an unforeseeable complication and didn't report that in the voluntary incident reporting. But by doing the Global Trigger Tool, we have started to change the culture that the health personnel now look at the wound infection as an adverse event for the patient, because the patient don't want to experience the wound infection, and you can't say that, well, it's predictive, you have to have 10% of your patients to have an infection. But as long as some other patients don't experience, then you should try to avoid infection in all patients. And mostly important, it's to get the boards on board. So we inform our trust board twice a year about our results, and we do that by making a dashboard with our GTT results and show them to the boards. And we suggest some initiatives that they could suggest that the trust should follow. And it's important to have a top-down engagement in order to get all of the divisions to do the improvement work if you have the boards on board. So by doing record reviews, we identify adverse events, and we identify the types of adverse events that you need to respond to, and you identify the severity of the adverse events. And you can track the rate of adverse events over time, even though it might not be the correct level, but you know if you do an increase or a decrease if you choose the same sample size over time. And you can use it in each division to evaluate the effects of the improvement work which has been started in each divisions. And the results are understandable because you get the result like the rate of adverse events per patient stay or per admissions or the percentage of admission who experience an adverse event. So it's understandable both for staff and patient. It's not any complicated relative risk reporting or something like that. And the record review is an all-cause harm method that includes the whole patient population. In quality register, it's mostly a designated diagnostic group of patients or a special procedure. But with this record review, you include the whole patient population, and you can find all types of harm when doing this.
I will tell you a little bit about Meetbaar Beter, an initiative of 19 heart centers. And maybe I should start off with a small lesson of the Dutch language. Meetbaar Beter means is Dutch for measurably better, and that is also the reason that I will keep on using the Dutch version, because the English one is a tongue breaker, and when we started Meetbaar Beter we didn't realize that we would be speaking also abroad about it. Meetbaar Beter is as I said, an initiative of 19 heart centers, and we're focusing on outcome measures, and we started measuring them, but that's not where we stop. We want to use these measures for improvements, and we're struggling with that. We're trying to find ways to use outcome measures to improve care, today we would like to share some of our lessons with you and discuss about that. These are the centers that are involved in Meetbaar Beter so far. So it's 19 heart centers in the Netherlands. And I will introduce Meetbaar Beter. I will tell a little bit more about the organization and how we set it up. And after that, I will give the floor to a colleague of mine who's a cardiologist, and he will tell about the physician perspective and explain how Meetbaar Beter has helped him to improve. I would like to start maybe with a statement just to know what my task is here, if I have to, how many people I have to convince of the value of what we're doing. So I would like to put this up for a vote. So the statement is: a quality registry without connected improvement initiatives has little value. Who agrees with that? I see a lot of people that agree. Maybe it was an too easy statement, but at least I know that then we can have a discussion on, okay, if we agree, then how do we do that? Because that's, I think, is the difficult part. So Meetbaar Beter uses these outcome measures to improve transparency and quality of healthcare delivery for heart patients. That's the goal. And I would like to highlight some of the specific elements, characteristics of our initiative. And the first of those is that Meetbaar Beter is transparently reporting all of its outcomes. And we're doing that no matter what the results. And I think this is something that we can really recommend. It has led to a lot of discussions, sometimes very heated discussions, because here, of course, also for political reasons, you see results shown where all of the centers are nicely within a funnel plot, which means that there's no outliers. But it also happens that centers are above the red line or below the green line, and that is where the learning starts. And I think that is one of our main messages, that this is something we use for improvement, and it's not that we want to say, okay, if you are above the red line, we give the results to the health insurer and you're not contracted anymore. No, it's a starting point for learning. We've been doing that for a while now. We started with 2 hospitals and has grown now to 19 heart centers, 19 hospitals, and we're covering more than 90% of Dutch heart care by now. We're publishing outcomes for the main medical conditions in heart care, so you've seen them listed here: coronary artery disease, atrial fibrillation, the combination of aortic valve disease and coronary artery disease and aortic valve disease itself. As I already started out, our aim is to improve, and it's also, of course, embedded in the idea of the statement. And Meetbaar Beter really uses the outcomes to improve. And here you see an example of how we do that. This is a page from our annual report. You can also find this in English on our website, the meetbaarbeter.com. And what we do is that we ask each of the centers to highlight what they have been doing in the last year to improve their outcomes. And we put that in the book also in a way to inspire the heart centers amongst each other. And we've seen a lot of initiatives that started in one center that are taken over by other centers or physicians that are calling each other. And I think that's another, important lesson which I did not expect, at least myself, beforehand when we started, and that is that Meetbaar Beter could have become something where you would have strong competition in a negative sense, in the sense that if one of the centers is outperforming the others, it's closing the doors and saying, hey, I'm good, let's see if we get all the volume into our center. But this is not what's happening. What's happening is that if centers are performing very well, then they would really like to share, and the physicians are getting together and trying to learn from each other. And here you see a small graph of the number of improvement initiatives that have been started. The way that we do this from Meetbaar Beter is that we as it says on the slide, we're not just a registry. So we do the basic registry things. We make an annual report in which we present our outcomes, but that's only the starting point. When we have this annual report, we organize events where we bring the physicians together to discuss the outcomes. And we're asking the physicians that, from the centers that are outperforming to think of why this might be. And this is a very difficult question always. I was also a little bit humbled by the presentation of Burik this morning. And he also stressed that you should be careful to run after random variations. But what we try to do is that if you see centers outperforming, you start a discussion and you start comparing the healthcare processes. And this leads to identification and rollout of potential best practices. So Jan-Henk Dambrink will go into that a little more in his presentation. But here you see a short example of that where the Isala clinic is a hospital which was outperforming on 120-day mortality after open heart surgery. And this was starting point of discussions regarding the question, what is causing that? And we think we have some idea. And some other centers started working in the same way. Another important lesson or characteristic of Meetbaar Beter is that the physicians are in the lead. I think this is a very important part, because we've seen in the Netherlands, and I assume probably also in other countries, that there's a lot of data being required for external reports, but nothing is being done with it, or only if in a negative way, if someone is performing below the requirements. Here it's really the physicians that are saying, hey, I want to know how I'm doing. I want to know, and I want to have the information. So it's the physicians that take the decisions. They are in the board of directors. They are developing the outcomes measure sets, and they're performing the audits amongst each other. Another thing that I would like to discuss, it's a little bit more technical, and that is that we believe that it's very important to always measure outcomes for complete patient populations. What I mean by that is shown here in this picture. You see here coronary artery disease, and if someone has coronary artery disease, you can measure the outcomes of the treatment. And what we are saying is that you should always measure the outcomes of all patients that have this disease, no matter what the treatment options. And you see the treatment options below. So you have the open heart surgery, you have the coronary percutaneous coronary intervention, and you have the conservative treatment. The reason that we say that this is so important is that you might get unwanted risk selection if you only measure one of them. If you only measure the open heart surgery, then it might happen, and this is something that the surgeons involved are afraid of themselves, that complex patients are not being treated, and the figures look very well, look very, very good, but they're not. So by measuring all of the treatment options, you can avoid this to a certain extent. I think I mentioned the word patient not often enough up to now in my presentation, but Meetbaar Beter is very much focused on patients. We develop the outcome measure sets, or we validate them also with patients. And here you see an example of us presenting the outcomes to patients using infographics. And of course, this one is in Dutch, as it's being used in the Netherlands. But you see here examples of survival, of reoperation, and of wound infections, where we try to explain in an easy way what you can expect if you're being operated or treated in one of the Meetbaar Beter hospitals. Another example of how we try to put patients at the center is that we're using a methodology which is really very closely, I would say, related to the work of Michael Porter's of the value-based healthcare principles. And we've selected outcomes at each of the levels of the outcome hierarchy as developed by Porter. And you see on the left column, you see the examples of you see the hierarchy itself, so survival, degree of recovery, time to recovery, long-term effects. And on each of these levels, we've tried to select the most relevant outcome measures, and you see them here also for the various treatment options. Another thing that we've learned, and maybe it's a very obvious statement, but we've learned is extremely important is to create excellent data quality. Because we've had in the startup of Meetbaar Better so many discussions with physicians when we want to discuss the medical content and the interpretation of the data, and you end up discussing the data quality because they're saying, this is not another center performing better than I am, or this is not our center being below the average, but this is the data quality that is causing this. So we're investing a lot of time and thinking into getting the data quality up to a level where this is trusted by everyone, and you can really use it for quality improvement. The last thing I want to say is, before I hand over the floor to Jan Henk, is I think also very much connected to the story of this morning of Mr. Berwick, and that is that we're in Meetbaar Better, we are trying to continuously innovate because what we're trying to do using these outcomes for improvement, it has a lot of pitfalls. It's very difficult. There's a lot of questions where we don't know yet how to do it, but we're trying. We're doing it. We're making the mistakes. But we're learning on the way. And here you see what we call the outcomes-based improvement cycle, what we're trying to go through and where we want to help the heart centers to improve. So the steps there, the monitoring of the outcomes, that's maybe the most obvious one where we have the outcome reports. But then step 2 is to get to improvement potential, to know where you can improve. Step 3 is to select what you actually want to improve, and 4 is to implement these improvements. And each of these steps, we're trying to help centers to improve. One that I would like to highlight is, or maybe two, given that I still have some time, is the maintenance of the outcome measures. We've set up a maintenance cycle of the outcome measures in which each year we discuss if the outcome measures that we present are actually helping to improve. If an outcome measure is flat over the years and nothing is happening, and we all know that it will stay flat, then you do not need to bother people with the registration of it and all the time that costs. And some new things might come in. So this is one thing that we've set up. Another is that we're continuously trying to figure out how we can better use the data to find improvement potential. And there we organize development sessions where we have physicians and have the discussion of what data do you want to have? What questions do you have that you want to have answered? And in that way, it helps us to further develop the report. So that was what I wanted to tell you. I will give the floor to Jan Henk, and after both of our presentations, there will be time for questions. Thank you.
Thank you, Paul. I would now like to continue with my part of the presentation. As was said before, I'm an interventional cardiologist doing PCI procedures and valve implantation, so more practical side of the story. First of all, I would like to say that we are very honored to be the guest of a true quality leader in cardiology. Sweden has been at the top level of quality registration in cardiology from the late 1980s on. They have a very good registry, very detailed, and the rest of Europe has not been up to that level until now, I would say. In 2004, by the European Society of Cardiology, initiative was started with a number of very famous cardiologists who came together in Ireland, in Cork, and they constructed a database about care and cardiology, and they put in every variable they could think of. It was an excellent database, but it was also very big. So it included, in the case of PCI only, percutaneous coronary intervention, 87 variables on the patient and the procedure, and another 25 on outcomes and patient follow-up. So for every PCI procedure, you had to fill out a form with more than 100 variables. So me as a doctor, I don't like that. So it was never a very big success, at least not in the Netherlands. And instead of that, the Meetbaar Beter initiative was started by 2 heart centers in the Netherlands, the Catharina Hospital and the Antonius Hospital. And they started this initiative, and it was mainly done, as Paul said, by doctors, so very practical. And for the case of PCI, percutaneous coronary intervention, the business of opening blocked coronary arteries, there are only 12 initial conditions of the patient and 6 outcome indicators needed for this database. And so how can it be so compact and concise? Well, there were international experts asked, what do we minimally need to truly properly describe the patient population and measure their outcome? And they came up with this very compact database. And the big advantage, of course, is that you can reach near completeness. The data we are presenting, at least are published, they're always more than 90% complete. And we weren't able to do that in case of the CARS database. And we also have clinically relevant outcomes because the experts were very keen on taking the right outcome measures. And the proof of all this was that we ended up with reliable statistical models. In the case of predicting mortality 30 days after PCI, we reached a C-statistic of 0.89, so with only this limited number of variables. So I think that's very efficient, and that's what doctors like. So this allowed us to detect improvement potential and reveal actual champions in the field. And before I now continue to how the data are presented and what we do with it, I would like to ask you if you agree with this following statement. Do quality improvements only be based on statistically significant data? If you agree, please show your ticks. Only significant, just a few ticks, a little more crosses. Okay. So the crosses are leading. Okay, we will see. Now, Meetbaar Beter is showing the results in various ways. Of course, we show the raw outcomes of each and every center. Actually, this was not very common in the Netherlands to just expose all the results of every hospital in the web and in the specialized and in the books we produce for that. Similarly, as in surgery, as was presented earlier this morning. So this was quite revolutionary, I think, but the data are all there for everyone to see. And next to the raw outcomes, we present segmented figures. For instance, the results of mortality figures divided in certain age groups or in patients with or without kidney failure to see which initial condition has the most impact on the outcome measure we are investigating. And finally, Paul already showed it, that we try to construct risk-corrected funnel plots where the average result of the whole population is shown with a 95% confidence interval. And this is then corrected for the initial conditions that are available in the database. Now I'd like to show you some examples of improvement projects to go a little bit further into clinical practice and to see what the use was for us of all these registers going on. The first example is about mortality after PCI in patients with kidney failure. Yes. This is about a hospital in Amsterdam, the OLFVG, that came into the program, entered the Meetbaar Better project in 2013. And when they looked at their own results, they found that mortality in patients with renal failure, the high bar over there, was seen particularly high. But if you just do statistics and say, well, we compare to another hospital, Catharina Hospital, one of the early starters, there was no significant difference. But, well, was it important? Was it not important? But if you study the relative risk, then you can see that the patient with kidney failure in Amsterdam had an almost 7-fold risk of dying compared to patients who did not have kidney failure. Well, as the additional risk, the relative risk was 3 in the Catharina Hospital. So there seemed to be a difference between hospitals. Renal failure had a different meaning in Amsterdam than in the Catharina Hospital, even though if you directly compare the results, they were not significantly different. So the doctors in Amsterdam went on to try and improve their program, especially for patients with kidney failure. Of course, there were already standard measures in place, like we all do as cardiologists, try to not to harm the kidney of the patient while you're treating the heart by stopping diabetes medication, give additional fluids, limit the amount of contrast you're using, and not do subsequent procedures within 1 week. So that's sort of standard care. But they went a step further and took additional measures. They made sure that from each and every patient it was known what the kidney function was. This sounds pretty logical, but it appeared that it was not the case. So made sure that they were aware of that. Furthermore, they went and differentiated in severity of kidney failure with regards to the amount of fluid that was given. A patient with a very poor kidney function had a longer pre-treatment period with fluids to prevent further damage to the kidneys. And they applied a weight-related formula to calculate the maximum amount of contrast fluid that was allowed. And they didn't allow for additional procedures, not within 1 week, but within 4 weeks, so that the patient could recover from the first procedure. And finally, they encouraged the doctors to use smaller catheters so that automatically you would use less contrast fluid. And with these additional measures, they saw a reduction in mortality in only 2 years' time from 9.2% to 5.0%. So that's an impressive reduction of an absolute 4.2% in a relatively short period of time. And if you compare this with the other centers, with the patient without kidney failure in light blue and the patient with kidney failure in dark blue, you can see the ratio has changed enormously. In the OLFVG Amsterdam Hospital, the relative risk for patients with kidney failure had decreased below 2, while it was near 7 when they started off at their new measures. And as you can see, there's still quite some work to do for the other centers to get the ratio down and improve the outcome of patients with kidney failure. I'd like the next slide. Yeah. Another example, vascular complications in TAVI. TAVI stands for transcutaneous aortic valve implantation. This is a relatively new method to implant a heart valve into a patient without opening the chest. We also do these procedures in our hospital and several other centers who are participating in Meetbaar Better. This can be done through a puncture or incision in the groin, or through a small incision in the chest. And the route that is taken is dependent on the quality of the blood vessels in the groin. If you have suitable blood vessels, you can cross it with a catheter without any problem. But if there's disease in these vessels, this route is not possible. And you have to ask the cardiac surgeon to make an incision in the chest, which is obviously more invasive and harmful for the patient. Now there are quite some differences between the centers, which way they treat the patients, which route they select. On average, between centers, it's around 60 to 70% transfemoral, so the least invasive way. But there are some centers, they do it differently. For instance, a hospital in Breda, they can go up to 90% transfemoral. So then you think, well, are the patients a lot different? If we look at the initial conditions, we think not. Is there less femoral disease in Breda? We don't think so. They must be doing something different. And especially, you would be interested if they have more vascular complication, damage of the blood vessel for trying to pass a vessel that cannot accommodate a catheter. But to our surprise, this hospital didn't have more, but have less vascular complication. So now you really have what we would call an access champion. They're able to cross a lot more blood vessels than the other with less damage. So that is quite remarkable. So this led us to study the way they treat the patients, and it was found that when entering the blood vessel in the groin, they didn't use a puncture, what a lot of hospitals do, but they used surgical access for that, and they preferably use very small diameter systems. So now the discussion is going on in the Meetbaar Better community. Should we all change our practice to the way of Breda is doing, or are there other methods? So this is really starting off a discussion in our development sessions we're having. A final example, Paul already touched upon this briefly in his part, Isala safety check. Isala is the hospital I'm working. We entered Meetbaar Better in 2013. We had our first report then together with the other hospitals. And right at the first report, it was shown that our results after bypass surgery were quite good. Mortality after 120 days was significantly lower than the rest of the centers. So then, of course, the question arose, what was the secret in Zwolle? Well, actually, we were not too happy with the bypass surgery results in the years before that. And to improve, an additional safety check was instituted. It is a short check of only 2 minutes just before the start of the surgery. It consists of a timeout procedure that almost every surgeon does in the world. Reiterate the Euroscore to get the global risk, but then again assess all risks in cardiac field, pulmonary, renal, or neurological field, the risk of infection, bleeding risk, and check off if all preventive measures that could have been done in the particular patient. Also, the anesthesiologist does an echocardiographic study to investigate the condition of the heart, and more importantly, in case of cardiac surgery, of the aorta, to make sure that the cardiac surgeon can place his cannulae safely. And this is also part of the safety check, and all these findings are then discussed and brought to the final treatment plan. Eventually, this could lead to postponing the operation because it's not safe to proceed at that moment in time, and you have to do additional measures and then continue with a new plan. These are the numbers, the mortality numbers in Isala itself, so outside before we entered the Meetbaar Better project. And as you can see, when we started this additional check, we found that overall in-hospital mortality decreased in a period of 3 years' time with 15% after each year. So this was also a quite remarkable result. This was also discussed within Meetbaar Better, and a number of centers, 5 to be exact, also implemented this additional safety check. And now, after a year, we can already see that they have changed their plan for the patient, for the surgery, by taking a different valve, taking another kind of cannulation location, using an intra-aortic balloon pump, and such. There are small changes, but they can have big effects. Until now, we do not know if this has effect on the outcome of the patient, because this is about 2015, and the report will appear at the end of this year. We are clearly slower than the Swedes. So to conclude, Madam Chair, ladies and gentlemen, I would like to say that Meetbaar Better has developed a comprehensive and near-complete database of patients with heart disease that receive an invasive form of treatment in the Netherlands. And this comprehensive database allows for benchmarking between centers and for comparison with data from the literature using weighted results. And I've shown you a few examples, and I think they demonstrate that even non-significant differences, but also ratios between outcomes, can help to identify improvement potential. And a study of outliers in risk-corrected funnel plots can help to identify champions in the field, like the hospital in Breda, or improvement potential in other individual centers. And most importantly, sharing of these results can help all centers to improve their patient outcomes. Thank you for your attention.